that are still on it from previous generations, and they're doing great, and they're staying on top of their health checks. And so it can be reasonable to continue them, but we should not start someone in their 70s on hormones.
So you're having those conversations, obviously, on a case-by-case, individual by individual, and talking all the pros and cons and other things. So, okay. Well, that's very, very helpful. You know, I know there were a few questions coming in around testosterone therapy. What are the downsides?
So the downsides to testosterone therapy is really in the formulation that it comes. When we're going to do testosterone, we want to use the transdermal form and do it very slowly and incrementally increase it. We do worry that since it's not studied in women, there could be an increased risk of some cardiac implications. What I don't love is the pellets that give you a really high dose of testosterone that slowly wears off over 3 months. Because if a patient does encounter an adverse outcome, they cannot take it back. They cannot remove it out of their body. Things that we see with too much testosterone is a deepening in the voice, increased hair growth, especially on the chin, clitoromegaly, where we see actual physical change in the genitals from the testosterone. So it is a medication that we have to be careful with.
So there are some downsides with that. Okay, great. And then one last question that had come in about hormone replacement was specific. Let me just put a finer point on this. After somebody who's had a total abdominal hysterectomy. The question about how long should it be there. Obviously, you don't need progesterone, as you were saying before. Right?
So since estrogen doesn't carry the same risks as progesterone, and the difference is if you have a uterus, you have to stay on progesterone. If you don't have a uterus, you can be on estrogen alone. If someone is in good health and the estrogen is helping them, I am very comfortable continuing patients on this for decades.
And that comes back, obviously, the uterine part, but that also comes back to all those side effects that the long-term study was showing in terms of Women's Health Initiative, where it's higher with estrogen plus progesterone, or therefore the progesterone than with estrogen. Is that right?
Correct.
Got it. Okay.
So we don't carry some of those same risks with the estrogen alone.
So then you feel much more comfortable saying, let's do long term. Okay. Well, great. Well, thank you. Dr. Ramirez, I want to ask a couple questions here that came in also. Can you talk a little bit about mental health programs that are offered specifically for women, and areas of concentration that might focus on that are obviously unique to women, like postpartum period, menopausal period, and others?
Yeah, well, thank you so much for bringing this question and this topic to light. Certainly we consider that mental health, and particularly related, as you mentioned, to maternal mental health, is critical, and is really very, very important to assess, evaluate, and potentially treat if this is the case. It is a very common problem, and certainly one that we're now developing strategies and initiatives to actually have a mental health specialist, a psychologist within the Department of OBGYN, and actually have someone where our patients will have an opportunity for direct referrals, rather than having to go outside of our institution. So we're in collaborations now with the Department of Psychology to potentially actually have not only a staff psychologist, but also possibly a fellow dedicated to maternal mental health. So we're really excited in that. I really hope that we'll be able to bring that forth in 2025.
Okay, fantastic. And, I noticed one thing in your slides, to switch gears back to some of what you're talking about and really all the quality initiatives. You showed an image of an article on the surgical site infection bundle. Yeah. If one looks at that article closely, the lead author at the listed last, I think, was a certain Pedro Ramirez. Am I right?
That's right. So
tell us a little bit more, because that's obviously very impactful nationally.
Yeah, we're very, very proud of this initiative, and as we all know, obviously, surgical site infection is one of the metrics that we look to determine the quality of care that is provided to our patients. So we really wanted to make sure that we had a set strategy and a structured strategy for our services, not just in gynecologic oncology or general gynecology, but also now extending to obstetrics as well. And the goal with these initiatives is to develop a multidisciplinary team. And that's really critical and important, that this is a focus not just on surgeons, but also bringing in the nurses, the preoperative nurses, the clinic nurses, the anesthesiologists, the postoperative nurses, to all come together and cohesively come up with a strategy as to how each of those domains will contribute to improving the outcomes of those patients. So that publication, we're extremely proud of that publication, because it was one of the first publications that I had here with our Methodist team, and it really outlines what we actually did and what were the implementations of that surgical site infection bundle and the steps to follow. So this has been an article that now frequently is requested by some of the leadership in quality and safety at our regional sites, and actually nationally as well, where they look and say, well, what's the formula at Houston Methodist? How can we follow that? And just to end with an example of the fact that when we look at our metrics in obstetrics and gynecology, from the beginning of 2023 until we started this program in November of 2023, we had a total of 7 surgical site infections. Since November of 2023 until now, Friday will be 1 year anniversary of the implementation. We have had 1.
Wow.
So it's really impacting, and we're very proud of it.
That's great. And it's multidisciplinary. Does it involve some preoperative steps from the patients and postoperative steps? So
yes.
Where's the patient's role in all of that? Because that's relevant to any real surgery that would happen.
Yes. I'm glad you highlight that, because the patients are critical in the success of the implementation. There's a great emphasis on patient education, so that the patients will understand the benefit of these implementations and these initiatives. And in fact, actually, it's very encouraging to see how patients actually take ownership of really being an integral part of the success of this. And we're just very, very proud to see that they want to take part in their own recovery and speeding up that recovery and reducing their infection rates.
That's great. Well, thank you. And I want to shift back because there's some other questions around screening and wellness and other things, specifically around, part of a well woman exam is obviously thinking about breast care and breast cancer screening risk. And a question specifically about, should I be just getting standard mammograms? Should I be requesting something more? I hear about ultrasounds. I hear about 3D mammograms, these kinds of things. What do you do as an OB-GYN who cares for women who are coming in and asking those questions?
Well, to break it down a bit, a traditional mammogram is where the breast is compressed and an x-ray is taken. The 3D mammogram actually moves the sensor around so that you get a better drawing or 3D picture of the breast. An ultrasound is using, it's an ultrasound